Good morning or good afternoon, good evening, wherever you may be. I'm Adam Lupel, IPI Vice President, and it is my pleasure to welcome you to this virtual policy forum on strengthening data to protect healthcare in conflict zones toward the implementation of UN commitments. I just started and the sun came out right on me. I'd like to thank the government of Spain for their support for this project and for their long-standing leadership on this issue. More than 6 years ago now, in May 2016, the UN Security Council adopted by consensus, Resolution 2286, which I think we can all recognize as a truly landmark resolution to condemn attacks against medical personnel in armed conflict. And Spain was one of the leaders in tabling this widely supported resolution, which was co-sponsored by more than 80 states. So we are very proud and happy to partner with Spain on this project. Resolution 2286 recalls the core commitment of international humanitarian law on the protection of health workers and health services in armed conflict and aims to, quote, ensure the respect and protection of all medical personnel and humanitarian personnel exclusively engaged in medical duties, their means of transport and equipment, as well as hospitals and other medical facilities. Regrettably, I think we can recognize that the Resolution 2286 alone was not enough. Violent attacks on medical care and medical personnel continue unabated around the world in far too many conflict zones. IPI has been concerned with this issue for many years, working and convening on this topic. In particular, it has been very important for us to help to reinforce the implementation of IHL and UN commitments toward healthcare in armed conflicts. And we have published several reports on this issue, including a report by Els de Boeuf in 2017 on evaluating mechanisms for investigating attacks on healthcare. And we have since organized a number of policy discussions on preventing attacks on healthcare, both here in New York and in Geneva. So our policy forum today seeks to build on those efforts to continue this work. Today, our focus is specifically on the use of data to prevent and protect against attacks on medical care workers and medical facilities in armed conflict. And as part of our conversation today, we are very pleased to launch a new IPI issue brief on strengthening data to protect healthcare in armed conflict, which has been co-authored by Susanna Sirkin and Rouhani Sahar, who are here with us today virtually. We have an excellent panel coming up to discuss these findings, as well as the quite extensive recommendations in this brief report. But before we move to the panel, I will give the floor to Ambassador Agustin Santos Maraver, Permanent Representative of Spain to the United Nations, for further opening remarks. Ambassador, please welcome. The floor is yours.
Thank you very much, Dr. Lupel. Yes, I think you can hear me. Thank you to everybody being here to this presentation of the IPI Institute in relation with the strengthening data to protect the medical missions. As it had been said, and we all know, the first Geneva Convention of 1949 established the importance of the protection of the medical personnel, and the additional protocol to the Geneva Convention deepens more in this essential question. But more recently, the global pandemic has reminded us of the essential importance of protecting medical missions in every single circumstance. Nevertheless, health facilities continue to be targeted, bombed, and destroyed, and medical personnel and patients continue to be assaulted, killed, or injured in many situations of arming conflicts around the world. The number of attacks and killings of humanitarian personnel has increased in the last 5 years, especially national medical staff. Last year, 3 Médecins Sans Frontières workers, including the Spaniard Maria Hernandez, were killed in the Ethiopian region of Tigray, and more recently, the situation in Ukraine proves to what point we need to continue working in this field. On November 2019, Spain organized a roundtable discussion on data collection in attacks to hospitals alongside the International Committee of the Red Cross in Madrid. The discussion showed how medical missions suffer harassment in all situations, even when an armed conflict is not taking place, not hot enough. To address these problems, the Security Council adopted Resolution 2286, promoted by Spain, Egypt, New Zealand, Japan, and Uruguay, and it was co-sponsored by 85 member states. In its Op 4 urged states and parties to armed conflict to develop effective measures to prevent and address attacks against medical personnel through data collection on obstruction, threats, and physical attacks on medical personnel. With the events and with the report of the International Peace Institute that we are introducing today, we contribute to fulfill this mandate, as Dr. Lupel has already pointed out. Data collection is important for many reasons. As the authors of the report will explain, strong data on the scale, context, and scope of the attacks to medical facilities are essential to understand the problem. An effective data system on attacks on health can provide guidance for protecting high-risk areas, can help raise awareness on the problem, and even if its primary goal is not bringing perpetrators to justice, it can also play an important role in the fight against impunity. Spain will soon approve a national strategy on humanitarian diplomacy, in which protection of medical missions and the need, of course, to collect data will play a major role. To conclude, let me point out the importance of the increasing weight digitalization has within armed conflicts. Drones, misinformation, malicious software against medical missions, even applications used by combatants to enhance their deleterious capabilities are being used more and more. We must respond to this challenge using digital technologies and their possibilities for the same purpose that inspired Mr. Dunant in the second half of the 19th century, to save lives and alleviate the suffering of the survivors in armed conflicts. Thank you very much for your attention.
Excellent. Thank you, Ambassador. That's a very good start. Let me again thank you very much for the partnership and also for your leadership on this critically important issue. I will now turn the floor over to my colleague, Agathe Sarfati, IPI Senior Policy Analyst, who is our lead on this topic and will moderate the panel discussion. Agathe, please, the floor is yours.
Thank you, Adam. Good morning, good afternoon, everyone. It is a pleasure for me to moderate this important policy forum to present and discuss IPI new publication on strengthening data to protect healthcare in armed conflict. Attacks against healthcare in armed conflict is a very serious humanitarian issue which can be approached from different angles, but today we specifically focus on the role of data to help prevent those attacks. Several initiatives have been established in the past decade to collect, report, and use this data, and we will learn about some of these in a few moments. These include global initiatives, such as the WHO's Surveillance System for Attacks on Healthcare, reports from the Safeguarding Health in Conflict Coalition, as well as independent initiatives, such as the one led by the International Committee of the Red Cross and others by local NGOs. We will see that the objectives and the way of working of these mechanisms are different, and that no data set can ever be fully comprehensive. So we'll try to answer the following questions. Why and what data is important? How is it possible to improve and harmonize some of the existing data collection efforts to enhance the protection of the medical mission in armed conflict? We have 6 excellent panelists to help us dissect the issue. We'll start with the 2 authors of the report, Rohini Har and Susanna Sirkin. We will then move to Hyo-jong Kim from the WHO to share some perspectives on the surveillance system for attacks on healthcare. We'll then turn to Maciek Polkowski, who is the head of the International Committee of the Red Cross Healthcare in Danger Initiative. We'll then hear from Len Rubenstein, the chair of Safeguarding Health in Conflict Coalition, the leading civil society coalition which reports on attacks on healthcare globally. And last but not least, we will get a perspective on the issue at hand from South Sudan, thanks to the participation of Tobijo Dennis Tokiri Moses from the Rescue Initiative in South Sudan. As you can see, our agenda is pretty busy, but we are planning to get to a short Q&A after the panel. So those of you who are in the Zoom room, please use the Q&A function to share your questions to the panelists. But without further ado, I'm turning to Rohini and Susanna to discuss the importance of data collection as well as their main findings and recommendations. Dr. Rohini R. is an emergency medicine physician and a faculty member at the University of Berkeley, California. And Susanna Sturkin is an independent consultant. She is the former director of policy and senior advisor at Physicians for Human Rights. Rohini and Susanna, over to you.
Thank you so much. Today, we're talking, as we've heard now several times, specifically about data. Now, we often think of data as statistics, numbers in a headline, in a UN speech, or in an academic article. But as science reporter Paul Brodeur notably wrote, statistics are human beings with the tears wiped off. In war zones, these human beings and the places where they seek treatment and life-saving care need our focused attention. We're talking about incidents affecting the health, lives, and very survival of hundreds of thousands of people, if not millions, virtually on every continent. Now, acknowledging and reporting the violence is a first and necessary step to addressing it. And yet we know that armed conflict and other extreme emergencies make everything about safely gathering accurate information even more difficult. As we've heard, protection of health workers and the delivery of health services are foundational to the Geneva Conventions. And so in the face of widespread attacks on health facilities and personnel, as Adam noted, in Syria, in Afghanistan, and other countries 10 years ago, we started to talk about the danger of a new normal. But it was not a new normal, as we know from Len Rubenstein's very important book. The flouting of this fundamental norm of international humanitarian law had been going on for decades without being systematically documented or reported. And by 2015, as we've heard, the egregiousness of the bombings of hospitals in Syria and devastating attacks elsewhere prompted the drafting of UN Security Council Resolution 2286 on protecting health in conflict. At that time, some of us thought, why do we need a new UN resolution? The laws protecting health are embedded in the already widely ratified Geneva Conventions. But these trampled norms did need reinforcement. And in 2016, the Security Council unanimously passed Resolution 2286, as the ambassador noted. But distressingly, the commitments of the resolution are not being implemented as envisioned. And so our concern here today is that the recording, reporting, sharing, and responding to the information that should be collected is frankly not adequate to the challenge. And that's why we are so very grateful for the initiative and support of Spain and the IPI and the more than 24 experts and stakeholders who spoke to us as we explored the obstacles and the opportunities for more comprehensive, detailed, and publicly available documentation of violent incidents against healthcare. This is not just an exercise in statistics, but in producing and using the necessary information to stop attacks, to protect patients, to support medics, to hold perpetrators accountable, and to save lives. So over now to my co-author, Dr. Rohini R, for an overview of what I found.
Thanks, Susanna. We've triangulated our methods to ensure a comprehensive understanding of what the state of the data are and what needs to be done to improve it. The experts we interviewed came from academia, civil society, UN organizations, and representatives of member states. We triangulated that knowledge with close reviews of the literature and policy, and with analysis of existing databases and data sets. We gleaned many insights from the interviews. primarily that the data and the details matter. One expert noted, if you reduce the data to a bean counting exercise, you've lost the plot. Another, data is step one, but data needs to be turned into actionable information. And finally, at the end of the day, we need to use data for actual changes to the system to protect health workers. The analysis also distilled how data can be used for protection, advocacy, and investigations. For protection, data can highlight who is most vulnerable, who needs the most support, and what exactly they might need by looking at what was attacked, what was lost or disrupted. For example, attacks on health in Syria have demonstrated the devastation of entire hospitals. Local and international reporting on that violence allowed for support for building hospitals in more secure locations, or sometimes removing emblems when they were found risky. Advocacy has always depended on naming and demonstrating that the laws were violated. And certainly data is needed for accountability. We are not suggesting that a broad database of incidents is sufficient for a legal investigation, but it can certainly be a starting point for prioritizing incidents that may call for an investigation, an early warning or sentinel system. The experts we spoke to also highlighted that we have not gotten it quite right yet. Most incidents go completely unreported, and there are countries with large numbers of attacks that get very, very little attention on the international or diplomatic stage. There's little understanding of the motivations or activities of perpetrators of attacks. And most obviously, attacks continue across the globe with little mitigation or accountability, highlighting that the existing responses are clearly not enough. We looked at over 20 data sets that document civilian violence publicly. We focused on two of them, WHO's Surveillance System for Attacks on Healthcare and Insecurity Insights Attacks on Healthcare project. Both report specifically on attacks on health, and both function more globally. They differ, however, in both their methods and outputs. To highlight a few distinctions, WHO is a member state organization. The SSA program is based on a World Health Assembly mandate and draws information from its health clusters, primarily in complex humanitarian emergencies. Insecurity Insights dataset is based on open source investigation and media monitoring. Its reporting is more detailed, covers far more countries, and identifies perpetrators when alleged or known. Ultimately, no one database is comprehensive. With the existing limitations in granularity and collaboration, it's hard to compare and identify the overlaps and missing pieces, underscoring the need for better data. And in addition to highlighting the need for deeper collection and broader geopolitical scope, we're also concerned about the access to information, especially for those that are inputting information into the WHO's SSA system. Without mutual data sharing, those on the field are less motivated to report, and it might not be sustainable. And obviously, there are legitimate security risks in reporting on violence, but we suggest that reasonable approach to securities must strike a balance between publishing important information and protecting those most at risk. Back to you, Susanna.
So we have concluded that no single entity can overcome all the gaps in data collection, its quality and depth, geographical coverage, public availability of information, and the naming of alleged or proven perpetrators. And so we stress the great need for coordination among multiple stakeholders and systems. Governments have an obvious critical role, but are frequently, some of them, compromised by their own collusion or even direct participation in violations. And WHO has a unique role and obligation as the lead institution for collecting such data. It is the directing and coordinating authority for health within the UN system, of course. And WHO can hold member states accountable for prevention and for protection. So as we conclude, the WHO must address current limitations, starting with an anticipated expert external review of the surveillance system's scope, reach, and impact. Our key recommendation is for the World Health Assembly to adopt a resolution calling on the WHO to address concerns in the structure and operation of the SSA. In addition to calling for an expert review, which could in fact precede such a resolution, elements of a World Health Assembly resolution include highest level or higher level management and oversight of the entire project, regular discussions with local and international stakeholders, greater collaboration with other UN agencies and civil society organizations, and confidential sharing of information on reported perpetrators with relevant UN bodies, such as the Office of the High Commissioner for Human Rights and the Special Representative for Children in Armed Conflict, as well as with independent commissions of inquiry. Now, additional recommendations we make zero in on technical improvements that could enable the SSA to leverage new technologies, such as those for open source investigations and remote surveillance systems that are being increasingly used to monitor attacks. We urge a more nuanced and context-specific approach to assessing security risks for sharing information and also for sharing with stakeholders and even the public. And finally, among other recommendations, we urge training of health cluster members, further training, and others for consistency in documentation and reporting so that more of the data are comparable. At the end of the day, this data that we are talking about today is for the purpose of saving lives, for stopping attacks, for accountability, and for prevention, and for all of us to understand what these statistics, these data actually mean and how to use them.
Thank you very much to you both for this presentation and for the summary of your findings and recommendations. We'll get back to the proposed way forward during the discussion. Now I'm going to turn to Hyo-Jong Kim, who is managing the WHO's Attacks on Healthcare initiative. Dr. Kim has been with WHO for 18 years, including in conflict-affected countries and working on emergency response and preparedness. Dr. Kim, the WHO's surveillance system for attacks on healthcare, as we just heard, has become the de facto intergovernmental and institutional leader on collecting, compiling, and reporting on data on attacks against healthcare. So we would love to hear your perspective about the WHO's added value in data collection and reporting and the potential to further strengthen the SSA to meet the objectives of Resolution 2286. Thank you. Hyo-Jong, you have the floor.
Thank you, and thank you for the invitation to this forum and for sharing the report on strengthening data to protect healthcare in conflict zones. WHO has been addressing the issue of attacks on healthcare for a decade since the passing of the World Health Assembly Resolution 6520 in 2012. And as a member state organization, we are guided by these resolutions, which is a way for member states to tell us what should be our work. And in this resolution, member states requested WHO to provide global leadership in developing a methodology for collecting and disseminating data on incidents of attacks on healthcare. WHO launched the Attacks on Healthcare initiative, Prevent, Protect, Provide, with the aim to ensure access to healthcare for all emergency affected population without being hampered by acts of violence or obstruction. The initiative and the subsequent surveillance system for attacks on healthcare, or SSA as we call it in short, were developed based on an intensive and transparent consultation process, which took 5 years and which included a wide range of stakeholders along the way. WHO's surveillance system for attacks on healthcare was launched subsequently in December 2017, and it is a mechanism for collecting data of incidents of attacks on healthcare, and is implemented in countries with complex humanitarian emergencies. Its methodology allows the documenting of attacks on healthcare based on a process of verification and provides data with a level of certainty for each incident. The resulting information is then made publicly available. Its methodology relies on reporting through partners with whom a clear understanding on the confidentiality of their reports and the relevant security measures for the system are in place. WHO's definition of attacks on healthcare is broad to be applicable to different contexts and is used to try to capture different types of incidents of attacks that hinder access to healthcare. The system does not aim to address all questions related to attacks on healthcare, as much of this goes beyond the mandate given to WHO. The data is used to highlight issues in different contexts and advocate for the prevention and protection of healthcare against attacks, and also to show trends in the prevalence of attacks. WHO is working to implement this system in all countries with complex humanitarian emergencies to allow us to generate a robust set of data to highlight the problems and further inform the dialogue on this topic. Having said this, WHO's decade of involvement in this topic has shown that despite all efforts to refine and collect the best possible data on the topic, attacks on healthcare continue to occur, as many of you have already mentioned. In 2021, an analysis of the 3 years of SSA data showed that attacks continue to follow the trend of conflict, increasing when conflicts intensify and decreasing when not. And this was yet again proven correct in 2022, not only in the context of the ongoing conflict in Ukraine, but also in several other countries and contexts with conflict situations. Data is important to show the magnitude of the problem and highlight where interventions are needed. And the trends of attacks from existing data already show that more action is needed beyond just data collection to fully address this issue and ensure healthcare is protected. While this report by IPI focuses exclusively on the issues around data collection, the UN Security Council Resolution 2286 requests all parties to armed conflict, including member states and the UN Secretary General and other stakeholders, to take critical action on this issue in its entirety. This highlights that the complexity and wide-ranging consequences of attacks on healthcare need a concerted and multi-pronged response to fully address the issue. We all share the same goal of wanting to ensure safe access to healthcare, as was mentioned. Attacks on healthcare affect the capacity of both local health systems and the humanitarian system to provide quality care, which ultimately affects the health of populations that we are serving. And this requires the involvement of many actors, as some of the key actions required to stop attacks on healthcare are mutually exclusive when performed by the same actor. We need member states, for example, to ensure proper measures are in place to protect healthcare and hold perpetrators accountable. UN agencies to document and advocate for better protection. Implementing agencies, civil societies, and other actors to ensure protective measures are part of their operations. Healthcare workers to understand and work towards protection. Academics and researchers to highlight impact, and communities to call for protection of their health resources so that they can have access to them when they need it. As you can see, everyone has a role to play, but no one can play every role. In conclusion, I would like to thank you again for inviting us to speak at this forum. We always appreciate opportunities to engage in dialogue on this topic and the constructive suggestions given to WHO and others for improving data collection. As I mentioned earlier, WHO has been working on collecting and disseminating data on attacks on healthcare for a decade now. Through this experience, we have seen that no database can be complete, but existing data can and does bring different elements to paint the picture and show the magnitude of the problem. I think we have enough data on the issue to show this. And if one thing is clear, it is that there is no evidence that attacks on healthcare are stopping anytime soon. And now it is time for more action. To truly address the issue in its entirety and prevent and protect health against attacks, we require stronger and collective action, capitalizing on the strength and expertise that we each have to bring to the table. As such, I would like to use this opportunity to call on all present and all other stakeholders to take clear actions to ensure that the sanctity and safety of healthcare, including that of health workers, patients, suppliers, transport, and facilities, are respected and protected at all times. It's only by working side by side and fulfilling each of our mandates that we will succeed in protecting the population we serve. Thank you.
Thank you very much, Yu Zhang, and thank you very much for this call for action. I'll now give the floor to Maciek Polkowski. Maciek joined the ICRC in 2005 and has been leading the ICRC's Healthcare in Danger initiative since 2018. The initiative aims to prevent violence against healthcare in acting at the national and local levels. Maciek, we are interested in learning how the ICRC uses data to fulfill this objective and your assessment about the importance of global and public data collection mechanisms. Maciek, over to you.
Thank you so much, Agathe. Good morning and good afternoon, everybody. Thank you for having me and allowing me to represent the ICRC in a key discussion on this topic that's at the heart of our mandate. When it comes to data, I think it's very important to underline once again, and here I agree with other colleagues, that data is first and foremost an enabler rather than a goal in and of itself. And this is how we conceive of it within the ICRC's strategy on protection of healthcare. This strategy places operations, doing things practically on the ground and also in terms of policy. And that practical action is enabled by mobilization and better data and research. And we think of research using a rather broad framework, and we're interested in multiple types of data. So first and foremost, our delegates who are active on the ground in more than 90 countries predominantly affected by conflict collect information on specific incidents, first and foremost in order to intervene directly with the authorities, with parties to the conflict, on what is happening and in order to prevent it from repeating itself. The vast majority of cases of violence against healthcare that the ICRC collects find their way to specific interventions of this type. Beyond that, we also think it's very important to work at the systemic level to integrate mechanisms for data collection in national health information systems, and we also believe that there's a need to bring in public health methods in order to document the prevalence of violence against healthcare, and these are two topics that were predominantly discussed in the 2019 workshop in Madrid that the government of Spain so generously supported. Otherwise, we also do work on documenting the impact of violence on access to healthcare, but also the impact of violence on the functioning of health systems, including in terms of the economic cost. And we also work with academics and other bodies to gather good practice and document what works, why, and how. So within this framework, we have a number of projects that have either already been executed or are ongoing. And here I'd like to mention a couple of examples. So we're working in Afghanistan on the impact of limited access to education for women and the long-term impact that this will have for the functioning of the Afghan health system. We've also done work with the Royal Melbourne Institute of Technology to see how Australia's experience in managing remote healthcare can be applied to conflict zones where healthcare establishments often operate in remote areas. We just completed an interesting prevalence study in Bangladesh together with the Center for Injury Prevention and Research. We've also gathered research groups around the world in order to work on this topic. Most recently, two such groups were convened in Brazil together with the University of Ceará. We've done interesting work with the Universidad de Rosario in Colombia, attempting to compare public health data with the kind of data that the Colombian national system has produced over the last 2 decades on such incidents. And we have multiple other studies in Nigeria, Honduras, Iraq, DRC, and so on and so forth, often combining the systemic approach with the protection approach and with dedicated studies that allow us to also see how the policies we promote impact on the security and safety of healthcare personnel. Most recently in Nigeria, there was a very large-scale study of this type done together with the Nigerian Association of Public Health Physicians in relation to access to care for people wounded with firearms. So once again, data is an instrument, it's an enabler rather than a goal, meaning that there are multiple approaches to data that are possible, and ideally they should serve specific preventive and protective purposes. Moreover, we're talking about something that's a highly complex, wicked problem, And therefore, what we need is not really a single database, but rather an entire body of knowledge that has to be developed by multiple stakeholders across multiple contexts and for multiple purposes. So I think it's very important, when you look at the failure of the international system to protect healthcare adequately, it's important to analyze the system as a whole, as opposed to looking at a single element within the system and drawing conclusions on the basis of that. This is not to downplay the importance of data, including global or supranational data. But I think here we really need more overt and more clearly defined theories of change that will tell us how exactly different types of data are supposed to lead to specific protective and preventive outcomes. And I think this is very often far from clear in the kind of debates that surround this topic. I think we also should be looking at other global or not global international mechanisms to collect data on various humanitarian problems. This is not the first time that we're having a debate about the global data system for protection and prevention, and we should be asking ourselves whether other mechanisms of the type that we're proposing here have the kind of teeth that we would like them to have, and whether these teeth have been strong enough to bite in the past. So I think these are all important things. And while we discuss the issue of global data, we should not forget that the Secretary General's recommendations also call for the establishment of national data collection systems. And I think we should also try to get out of this dual, simplistic binary thinking where local data collection is seen as potentially, under a bigger threat of lack of independence, lack of neutrality, and so on and so forth, whereas an international system somewhat automatically is assumed to have a greater degree of such independence. So I'll stop here. Thank you very much once again for having me. And I second my colleagues' remarks that this is something that very much requires joint efforts and cross-sectoral collaboration. Thank you.
Thank you very much, Maciek, for presenting the Healthcare in Danger initiative and for this very interesting perspective, and really your emphasis on the need to develop a strong body of knowledge rather than focusing especially on one or two level of specific elements. So this is a good segue to our next speaker. We're now moving to Leonard Rubinstein, the founder and chair of the Safeguarding Health in Conflict Coalition. Len Rubinstein is also a professor of the practice at the Johns Hopkins Bloomberg School of Public Health, the director of the program in Human Rights, Health and Conflict, and a core faculty member of the Berman Institute of Bioethics and the Center for Humanitarian Health at Johns Hopkins University. Len, in 2011, you pressed for the World Health Assembly to establish the responsibility of WHO for collecting data on attacks on healthcare. We're very interested in hearing your assessment of this work more than 10 years later, and also as the chair of the Safeguarding Health in Conflict Coalition. We're very also interested in hearing about your views regarding the civil society's involvement in data collection and reporting, as we just heard the call for a large body of knowledge to be developed in this regard. So Len, over to you. Len, sorry, you are on mute. Thank you.
Thank you, Agathe, and thanks to IPI in Spain and to the authors for their insightful report. The report, in fact, I think represents a kind of marker of how far data collection efforts have gone since we started pressing this issue through the coalition and with WHO a decade ago. It shows how far we've come and where we may need to go. The progress we've made has been quite substantial. It's important to remember that as recently as 6 or 7 years ago, there was virtually no regular collection and publication of global data on assaults on healthcare. Now there are multiple reporting entities, varying methods, including increasing use of technology, including satellite imagery and related geospatial methods. In the short time, NGOs, civil society, and WHO have all been producing and posting data. The WHO's tracking of the now more than 700 attacks in Ukraine have shown the power of a UN agency publishing this data. It is regularly cited in the media. No one can ever say that we didn't know what was happening. So we are grateful to WHO for that work. The report is itself an indication of how the conversation has changed in the recent decade. Unlike in the past, where most discussions sought a holy grail of one institution perfectly situated to collect, analyze, and report data, we've heard a consensus today reflected in the report that we need multiple systems that build on each other and can together provide a more complete picture. It's also true, as the authors say, that the WHO is still essential as the world's global health agency, but there is a large place for others. What is much more important is that the different entities share data appropriately, that there is serious engagement with civil society, and there's collaboration in many other ways. Another change is reflected in the report's discussion of naming names, naming perpetrators. The report moves beyond the increasingly sterile debate about whether entities collecting data should be expected to conduct full investigations to ascertain legal guilt. Of course, that is not the case, and that was never the proper question. Rather, the report is correct that the data can suggest who was responsible for an attack without purporting to establish legal culpability. And then it can share the data with agencies that have a mandate to engage in further investigations and pursue accountability where warranted. Other lessons have been learned too in the last few years. A lot of data has been published now, naming locations of attacks, names of facilities, details of attacks. And there's no strong evidence that that publication has resulted in increasing security risks. Instead, where there is a security risk, in a particular case, the information can be suppressed. But it shows that a blanket policy of not publishing data on details and location is not warranted on security grounds. Still, there's a lot more to take stock of. And I'm particularly going to focus on WHO because I think the report is very insightful in talking about a review of leadership, management, methods, transparency, data sharing, and other practices at WHO, including linkages with other UN bodies concerned with accountability, as well as taking advantage of new sources of data. I think the recommendations are quite strong and support the potential WHO resolution regarding changes in the system. I want to focus on one thing that has been mentioned before, but I think deserves great emphasis. As in Ebola, as in COVID, independent expert reviews of WHO's work has proved both useful to WHO and important to the world and the global health community. 2 years ago, a group of experts, most of whom are epidemiologists and have a long track record of working with WHO, urged that in light of the opacity of implementation, gaps in data, apparent lack of following WHO's own published methods, and lack of transparency an independent outside review should be conducted. A year later, in 2021, WHO agreed to an outside review. But now, another year later, to my knowledge, none has been initiated. I suggest that the WHO Executive Board require such a study when it meets in January. And I think WHO itself will be agreeable to it. So thank you for the opportunity to make these comments, and I look forward to the further discussion.
Thank you very much, Len. We are now turning to Tobijo Denis Sokiri Moses. Tobijo is a technical advisor for the Rescue Initiative in South Sudan, a national NGO which works to alleviate suffering and address health issues at the local level in South Sudan. Tobijo is also a national NGO representative to the Intercluster Coordination Group hosted by OSHA in South Sudan, and he recently participated in a survey organized by the International Rescue Committee on Protection of Healthcare in South Sudan, a survey that aimed to complement existing data collection mechanisms by directly asking frontline health workers about their experience and own perspective. Tobijo, it would be very important for us to learn from the challenges faced by medical workers in South Sudan, the challenges to collect data about attacks, and the way this data has been used to mitigate the problem in the country. Thank you. Over to you.
Thank you so much. I hope I am audible enough, and thank you for the introduction. Just to start with, I would like to pick up from many of the speakers who had given. Am I audible enough?
Tobijo,
are you getting me? Are you able to hear me now?
Yes, here we can hear you.
Yes. So I said I want to start with by picking up from the last speaker, and I want to say that the attack on healthcare dimension in South Sudan has taken a different direction. In this country, unlike the traditional reasons for attacking healthcare, we now have issues that are settled within the community, and that includes issues of grievance, especially revenge attacks, and then the economic crisis and some political issues. So attacks on healthcare in this country is now occurring most at the sub-national level. But what are the challenges then that healthcare service delivery is faced with in this country? We have chronic lack of medicine and equipment. We now know that with other priorities, we have issues of lack of funding. And then we have inadequate and qualified staff. Now, how has the violence on healthcare impacted on the service delivery? We have seen that medicine and medical equipment are looted during situations of sub-national or national violence. We have seen that because of the protracted nature of the crisis, donors have become fatigued, or because of access constraints, funding has been stopped in some locations. We have also seen staff fleeing or suspending services or unwilling to return to their places of work because they feel unsafe. Now, what challenges do we see as, particularly as a national organization within our network in collecting data on violence on healthcare? We have come recently to see that data on attack on healthcare is very sensitive, and because of the fear of reprisal, considering that the perpetrators are powerful people within society. Because of the nature of this country, poor road network and access to telephone and internet, we have also seen logistical barriers. And because this conflict is protracted, the issue of violence has become a normal way of life in this country. We have also seen that while the WHO surveillance system on attack on healthcare is well used, there is not, it does not cover all incidents. And then there is high human resource turnover and lack of information that can be used to help protect the staff based on this data. Now, what role do we play as local health providers? We can provide eyewitness accounts. And earlier on, we talked about what really the surveillance system and the data collected can do to this country. We know that local actors can provide detailed information that is more qualitative, that dissects through the cultural, religious, and ethnic dimensions, other than just documenting violence, attack. We also know that the local health workers can predict potential risks and provide early warning, especially that they are based in the community. They are the first to intercept rumors through social media and hate speeches. We also see that local actors can widen the coverage. We're talking about community-based health workers who live in the community. I would like to stop here and thank you so much for listening.
Thank you very much, Tabijo, for sharing about your experience and about the reality in South Sudan, as well as about the role of local health providers in data collection efforts. So we've now heard from all our speakers who provide a really rich overview of existing data collection mechanism in place, their purposes, and who share really a recommendation to strengthen the overall system. So we have a bit more than 30 minutes for our Q&A session. So those of you who are in the Zoom room, please write your question in the Q&A chat function. But in the meantime, I'll ask the first two questions to our panelists. So the first one is really about one of the main recommendations of the report, of IPI report, which is calling for, as it was mentioned already, the World Health Assembly to adopt a new resolution to address some of the current limitation of the surveillance system for attacks, as well as for the WHO to reinforce the SSA. So I'm curious what steps you would recommend taking to translate these recommendations into reality and addressing any political challenges that might entail. So maybe first turning to Susanna and Rohini for this, and then maybe Len and Hyojong, if you'd like to take the floor.
Well, I'll just say, first of all, thank you so much. This was really a rich set of presentations. And although it may sound like there are quite a number of sort of tension points and disagreements, there's also as Len mentioned, a really strong consensus on a need for greater collaboration, and the fact that data are as Maciek said, are complex, and there's a need for multiple levels and layers of data, and looking at systems and looking at, in particular, at the purposes of the data. And I think we've just heard from our colleague from South Sudan why at the very local level, understanding the nuances, the particular situations are important, but at the same time that people locally need to see that a global effort recognizes them, acknowledges what's happening to them, and can be used for responding to early warning, et cetera. And so how to pull all this together with the external review that I think so many people have been waiting for and hoping for, and what leadership is required there. I think that Len's idea, for example, of bringing that, if necessary, to the executive board. I believe that the WHO does intend to do this external review, and I'd be interested to hear from Hyojong if that's on track and if it's going to happen, because all organizations learn so much from having someone from a few steps removed look at that. But as to the larger issue of a World Health Assembly resolution, I think we really need to look from, as one always does in such a resolution, leadership from the governments, from hopefully from Spain. I would be very interested to hear what the ambassador might say about it, whether Spain would be interested in leading on this, but also others, the pen holders of the original resolution 2286, as well as we have the group of friends of 2286, other countries, I think, that have taken a lead and strong interest in this issue include Canada, Switzerland, and many other countries where the challenges are right there on the ground.
Thank you, Susanna. Brainy, would you like to add anything? Okay. And then, would you like to take the floor?
You asked about the political dimensions. I think that member states have been very supportive of this initiative over a decade. And I think they're very committed to WHO's role in it and committed to making sure that the system works as well as it can. So I think that the kind of resolution being proposed by the authors should, of course, be discussed with member states, but I think it should have great political support. I don't think this is a very heavy lift.
Thank you, Len. Yo-Jung, would you like to take the floor at this stage?
Sure, I just want to highlight that indeed the commitments from the member states have been very strong, which is really good. But I think the way the methodology has been developed over 5 years of consultation with different actors, including member states, is the reason why the commitment remains strong. So if that's something that needs to be reviewed, I think that's a discussion that needs to be had among member states first and foremost. Before, I mean, we are a member state organization, we listen to the member states. So before that can happen, I think that discussion will need to be happening within member states. But I do also want to highlight again what I said in my remarks, is that I think this question requires action from all sides. And as I mentioned in my remarks, this requires actions from different entities who have different mandates and who can address the issue from different sides. So I thank you for the accolades given to WHO for our leadership role in this, but I think WHO is also just one of the players in the bigger jigsaw puzzle that needs to pull their weights together to address this issue. So I think instead of just putting all your eggs in one basket of WHO, it might be good to indeed have a full discussion amongst everyone about what role each can play to really ensure protection of healthcare on the ground. Because I think we've, in my 4+ years of managing this work, we've had this discussion over and over and again. And unfortunately, it's been the same people around the table, and we still haven't addressed the issue, but attacks continue to happen, as we say. And I think it's time maybe to move on and try to see what else can be done. What can we do? What are the actions we need to take, aside from just collecting data? Because that's the question I get asked when I go to the countries to try to implement the SSA. They say, well, how can this data help to protect our health services? How can they ensure that our patients have a safe access to healthcare? And I think that's a question that everyone has a role to play to answer. And data is going to answer one of them, but not all of them. So I think that I hope when we next meet, we can have a more productive discussion on the actions that each of us can take to really address this issue and move on a bit more from the data discussions alone. Thank you.
Thank you very much, Yo-Jung. Maciek and Tobijo, is it something you'd like to comment on?
Yeah, I think I'd like to echo some of the remarks that were made before, in the sense that it's very clear to all of us, I think, that the data we have is not comprehensive, that we are dealing with a lot of underreporting at all levels, and as much as it is important to keep pushing for better data and better reporting, we should be also asking ourselves, okay, we don't know everything, but isn't what we already know not enough to do a lot more than we are doing? And I mean, I'm using the we pronoun, but what I have in mind is really the member states, because if we speak about the resolution 2286 or the Geneva Conventions or other international governance instruments, they first and foremost impose obligations on the member states, and those obligations are not being fulfilled, and they are not being fulfilled by the perpetrators of violence, and there are many. But they are also not necessarily fulfilled by states who are not parties to conflicts currently, but who nevertheless, based on their signatures under the conventions, should be taking steps to domesticate those rules in their national legislation and to translate those rules into specific action of kind of preparatory and preventive nature. And I think it's also interesting to note that to notice that where we see states take serious action on data and on evidence, that's often concomitant with a general commitment of those states to also take other types of action in order to protect healthcare. So the data is not necessarily something that comes externally, that precedes all kinds of actions, but I think we in certain cases have more of a virtuous circle type of a situation where the more states do, the more they invest in it, then the more awareness they raise within their own apparatus, especially within ministries of health and health systems, the more it leads to better reporting and so on and so forth. So yeah, this is quite good.
Thank you very much, Maciek, for mentioning those important points. Tobijo, is it something you would like to comment on?
Yeah, thank you. Just to give a very brief comment, I know that global proposals and global resolutions rarely take a deeper root in South Sudan because of the highest level of impunity. So if we have to benefit in any way from both data and action, as a country and at the global level, we would rely so much to be supportive to come up with local issues, particularly in addressing subnational violence and attacks on healthcare. Thank you.
Thank you very much. Brainy, would you like to take the floor? Please go ahead.
Yeah, I wanted to respond quickly just to the question of, isn't the data we have already sufficient? And having done all this research, I think no. There's huge gaps currently in even, some countries where there's such limited data that it doesn't appear that there's any attacks. For instance, a lot of my research on attacks on healthcare is in Colombia. And there's no attacks on the SSA dashboard there, but our 2 or 3 years of research show that there is. And I would also say that it might be enough for really broad advocacy showing that there's, a lot of attacks globally and that this is something we need to focus on. But if we're saying that what we really need is action, then perhaps as an academic or a researcher, I would say to ground that in evidence, more granular evidence about exactly what's happening, the details, the perpetrators, the characteristics of an attack, the local locations, not just the names of the country, but really where that is and who's doing it and how that's impacting the health workers. All of that information, even in basic categorical data, is really not there yet. And at a global scale and at a local scale could be incredibly useful for research, for advocacy, for protection, for humanitarian organizations to use it. And I think having done all this research, that's what our paper is suggesting. Not that action is not as important and not that everybody doesn't have a role, but that for the data angle, there's still a lot more that can be done to get it right, and that we have an obligation to get there. Thank you.
Thank you very much, Rainy, for reinforcing those points. We have actually a few questions from the audience, and one relates actually to the question of security and safety of health workers regarding the data. So I'll read the question. How can we be sure that sharing specific location on health facilities will truly lead to better protection of our staff? And how can we make sure, again, that reporting on location and victim does not represent a security risks? So I'll see who would like to go first to answer this question.
I can briefly respond and say that in our interviews and in some of the research that we've done, there's been many cases where locations have been reported, especially in news media, in investigations by human rights organizations, things like that. And we're certainly not saying that, publicizing all locations is safe, but that really it needs to be a case-by-case contextual approach, where a blanket ban on publishing locations doesn't necessarily fit the bill, and that in some locations it's been done, we've seen that it's been safe, and it needs to be really contextualized.
Rachel, please go ahead.
I want to add that it depends on where that is, but in South Sudan particularly, even if you don't publish location, the political and the subnational nature of the problem is that the issue is already known up to the lowest level. So it's still, you cannot hide these health workers from attack or the facilities by just not publishing them, because they are known, it's happening at the grassroots. So it's all about its contextual, as put before.
Exactly. If I may, I just want to add that what Tobito just said completely echoes what I was going to bring forward, which is that there's so many situations where in the course of my work over decades on this problem, where people said, oh, well, if you report it, it's going to put people at further risk. And my experience and the experience that Rohini mentioned from the research we did in preparing this paper is that in most cases, the opposite is true. And somebody mentioned in the chat the question about the deconfliction mechanism in Syria, that has been widely covered and reported on, where there was an agreement among health providers from different NGOs, UN-supported systems with the UN to actually share with parties to the conflict. Well, in particularly Russia and UN allies or other allies, Turkey and so forth, that where the locations were of certain health facilities in northern Syria. And the fact of the matter is that those groups knew that the perpetrators of attacks knew very well where all the facilities were already. And the purpose of that exercise for those involved who shared their data was indeed to say, we're going to put this out officially through the UN system. And if there's an attack on those facilities, it will clearly be known to the world that you knowingly, intentionally targeted a facility. And that is in fact what happened. It wasn't the people who shared the data knew that the perpetrators knew where the facilities were. So that can also happen in certain circumstances. And we've also seen from, for example, Ukraine, I mean, now with geospatial technology, where a hospital is and even damage now can be reported and seen from the skies and from the ground, as in South Sudan. So that is why we are calling strongly for a much more nuanced approach and a case-by-case approach to security. It's not to say that there are not certain circumstances where sharing information could put people at risk, and that needs to be determined at the ground level, usually.
Thank you. Anyone else would like to comment and to answer this question?
Can I add a point here?
Go ahead.
I just would like to come back to what a colleague from South Sudan mentioned about the need to look at context. And I think that's a very, very important point. We can't just blanketly say, yes, you need to share all these information points because they're going to help do whatever, which is another question that hasn't been answered yet, in my opinion. Yes, data sharing, but we never answered the question, for what purposes, to answer which questions which really have an impact to protect our healthcare workers on the ground. So that's one question that needs to be answered when we talk about sharing further data points. The second point around location sharing is that as we did our consultation for the SSA, one of the key points that has come up in multiple countries is the need to not share location, because this does indeed put health resources at risk. And yes, as you say, Susanna, maybe it may raise the profile of an attack if their locations are shared, but that doesn't excuse the fact that there should be no attacks at all to begin with. So what we should be preventing attacks, not trying to advocate for, when attacks happen, that attacks should not stop. So I think that's a bit of a different discussion that needs to be had. And thirdly, I think when it comes to data, so for the SSA, as I mentioned, people were very, very clear about not sharing locations because their confidentiality and the risk that they are putting themselves into by reporting such attacks is actually quite significant. Now, and I agree that sharing location and other data points may be useful in different contexts to answer specific questions that are needed to target interventions around protection of healthcare. And that's why if that discussion is needed, that discussion can happen at the local level, within the local context, and with the understanding that it's being shared confidentially to answer a specific question. However, as a global system, we cannot just chop and do one thing for one country, do another thing for another country, because if we do one thing for one country and in another country that's a taboo question to be asked, that just takes away all the validity of the system in general. So I think that's something that needs to be kept in mind as we talk about the SSA or any other data collection mechanism going on out there, about the need to ensure that the proper risk reduction measures are in place, the ethical measures are in place around data sharing policies, and that the contextual aspects are in place. But most importantly, that we don't allow the data to be used to create further risks for our healthcare workers and create further attacks. So I think that's a very critical point we need to keep in mind. Thank you.
Can I just add one thing which has to do with the costs of suppressing a lot of information? If you take Ukraine, which we've been talking about a lot, I mentioned there were more than 700 attacks reported by WHO, and none of them are location information provided. On the other hand, the Ukrainian Healthcare Center, a local group, along with others, and Insecurity Insight have actually produced a map of where the attacks are taking place. So it shows location. And what that shows is enormously illuminating. It shows the patterns of dates, trends, how the attacks are related to current fighting. It gives a wealth of information that is relevant for accountability, it's relevant to protection, it's relevant to the day-to-day. And to my knowledge, although you may have different information, Hu Young, to my knowledge, that map has not generated any further attacks based on the map itself, that is the location data. So I think we have to look at the cost of suppression of information as well as the risks, which are real in some cases, of publishing it. And we have the same problems in places where it's difficult to obtain data, like Ethiopia, where we know that in Eritrea and the surrounding areas, not Eritrea, in Tigray and the surrounding areas, there have been many attacks, but none are officially reported because it's very difficult and there may not be cooperation from the ministry and there are blockages of communications. But not doing that means the world doesn't know. And so we have to think about what that cost is. Where is the diplomatic pressure if there's no official report that says healthcare is being attacked? We've talked a lot today about it's not enough to collect data. We have to do something about it. But if the data says there are no attacks, then there's no basis for anybody to take a risk to try to stop them. So I think we have to take into these kinds of considerations into account when we consider what information is gathered, what information is published, what kind of information is published, and the like. Thanks.
Thank you very much, Ben. anyone else on this question? I mean, Maciek. So, well, so thank you, Len. Also, you also answered in a way to one of the questions that was raised in the chat around the impact of lack of actions on the data collection process, and this was discussed also during the presentations around really the need to have this data to be able to take action from there. So something that you all mentioned is really the idea that we need to, I mean, a lot of mechanisms exist, and that there is a need to generate more coordination amongst those. So I'm interested to ask you, how can collective action be strengthened to protect the medical missions? And I'm also calling on the audience, if we're going to have just 10 more minutes, so it's the time if you'd like to ask another question. But in the meantime, if one of you would like to address the question I just shared.
I'm not sure if this is a direct answer to your question, Agathe, but in terms of this discussion about what actions can be taken for prevention and in response to the data that we've been sort of circling around, I think obviously there are many different types of actions that can be taken to prevent, protect. And of course, there is a theory of change that says very strongly, and I'm a party to that theory, among others, I'm sure, around us, that when there is complete impunity for this type of violation, which in many, many cases that we're talking about is a war crime, then there certainly will not be an end to the violence. And so documentation, reporting, including sharing of information with those entities, including UN entities that are responsible for evidence that will lead to accountability, as well as at the local, national, or regional levels, is one very important use of the data. And as Len said, when there is a global map, and in a place like Ethiopia, including Tigray, there are no attacks reported, one can easily assume that people there who are on the front lines, who have been attacked, who know very well what is going on, and they see nothing, leads to a sense of despair, hopelessness, and also a proper lack of response. But at the same time, no one is saying that data alone are going to solve the problem. But without accurate data, we can't do the important work, whether it's at the local level or at the national level or international level, to protect and prevent. And it is absolutely an essential element. And I think what we're saying here is that so far, it is not adequate to the task. But I think all of us have been involved in efforts to do actual prevention work. And of course, I totally agree with Maciek that in the first instance, it is governments that have the serious obligation to implement the calls for prevention and protection in Resolution 2286 and their obligations under the Geneva Conventions.
Thank you. Marini?
I just also wanted to add, echoing Susanna's points and adding that, and I think knowing exactly the communities that are being harmed most, often the health workers, can really help in coordinating both a global and local response to support health workers on the ground. And I think both in terms of resources and making sure that they have training and mitigation, but also because violence against healthcare poses an incredible moral injury to folks who are trying to do good work and yet feeling so insecure. And I think knowing exactly where those communities are, as we do from a lot of other research, maybe not the databases, has helped us really support those communities and figure out what they need and what we can do globally to support them.
Thank you. Would any one of you would like to respond on the way to move forward to reinforce coordination between the different actors while also potentially remaining true to each other, to each system's own objectives and purposes.
I would like to add a point, if I may, just jumping the queue here. I think we need to, because this whole report was commissioned based on a review of the UNSC 2286 implementation, I think we really need to go back to what was mentioned there, because I think the resolution does indicate very clearly what needs to be done by different actors, especially at the global level. So I think I really hope in one of our discussions in the future, and I know there has been member states discussions on this in the past with clear action points, but I haven't seen any of those action points being implemented. And since the report was commissioned by the Spanish government, I would like to call on them and on the other member state or the states to really look at what their roles should be within the as listed in the UNSC 2286, and to have a reflection on what has been done, what has not been done, and what can be done. I think that will indicate very clearly some of the actions that can be taken, especially at the global level. Now, at the local or the country level, of course, that, as I mentioned, that needs to be very much contextualized depending on the situation and the needs, and because every attack is different in each context. So that needs to be looked at and within the context. But I think at the global level, we do have a list of very clear actions that need to be taken as agreed to by the member states of the UN Security Council. So I think that should be revisited. And I hope that is one discussion that we can have in the near future, because we would really like to help contribute to that discussion. So that whatever we do, we make sure that it fits into the bigger picture in the scheme of things. Thanks.
I think I'd like to circle back to what was said before about the need for contextualization and also about the different motivations for the attacks. And you're right about it very eloquently in your book, Len. And I think, you know, now I'm going to simplify this framework a little bit, but I think one could, I find it tempting to divide the attacks into two broad categories. One is where they take place due to technical issues and where there is receptiveness on behalf of the state or the military force or armed group to achieve a certain level of improvement. And this is where you also have receptiveness for data, and you have a fertile ground to work with those stakeholders using granular information in order to strengthen those technical systems that eventually allow for, you know, better civ-mil coordination, better targeting procedures, better evacuation mechanisms for the wounded, and so on and so forth. And the other category would be where you have a deliberate policy of attacking basic infrastructure, healthcare, including healthcare, and so on and so forth. And I think paradoxically, these are also situations where there tends to be ample evidence of those attacks or of the perpetrators, and where a lot of that evidence also tends to be in the public domain, amplified by the media. It tends to come from multiple stakeholders simultaneously. And this also shows that at times, even having very rich data and very public awareness of that data and the problems is insufficient in order to deal with the issues, because the barriers that exist are of political and not epistemological nature. And I think I know obviously we're engaging in this discussion, all of us, in a good faith, and so are the member states that have patronized this cause over the years. But I also wonder whether, to an extent, there isn't a risk that by the singular focus on data, we take away the attention from the fact that there's just so much more that needs to be done in order to prevent the attacks, and that in many cases it's far from obvious how these problems could actually be resolved.
Thank you, Maciek. Does any one of you would like to comment on this question again? After that, we'll just do a last tour de table from all of you for a key takeaway before we close. Okay. Then I suggest we do our our last up to hear from all of you. We'll go in the order of speaking, starting with you, Susanna and Rohini.
Yeah, well, I'll just follow on what Maciek said, because I think what you just described, even if it's somewhat simplistic, these two groups, what I think our paper is showing, and as well as the recommendations, is that indeed a much more nuanced, granular, qualitative understanding, as opposed to just a bunch of numbers and looking at some kind of global trend, which may be okay and useful, but is not what we're talking about, is essential to tackling the problem, because without understanding just what, as you said, the motivations, who the perpetrators are, why it happened, what kinds of weapons were used, all of this is part of the data. And I absolutely want to make clear that this was a particular project to look at data, but not as if it is the only or even the most important priority for dealing with all of the lack of implementation of Resolution 2286. So I want to echo what our colleague from WHO has said, which is absolutely, we would all welcome much deeper investment and engagement with the implementation of all of the actions called for by Resolution 2286, but not to ignore the fact that if there are huge gaps and inconsistencies in the data, we cannot tackle the whole problem and do the actions that are required.
And I can't end without a plug for hoping that folks will read the report in detail, because I think it touches on a lot of these points in more specificity. And also really, I appreciate folks on the call agreeing to more engagement and collaboration on this, and I'm looking forward to that.
Ditto.
Yeah, John.
Thank you. I just want to end with what I said before. I think discussions are always good on this topic, and we do appreciate the space given to us by different states and other partners on the ground to discuss this topic further. I do think we need more collective action to really look at the protection elements, which has, I think, gone quite missing, unfortunately, till now. Yes, data is important. I'm the last person to understate the importance of data, of course, but I do think that action is also important, and we haven't seen enough of that. So hopefully in our next discussion, we can have a much more rounded discussion on different points that need to be in place to really ensure that healthcare is protected, that we really ensure that our healthcare providers can work in safety and people can have access to healthcare. Ultimately, that's what we need, no? Thank you.
Thank you so much. Maciek.
Thank you so much for the invitation, and congratulations to the authors, and thanks to the IPI and to the government of Spain for sponsoring this important project and for creating the space for the debate. I hope the collaboration on this crucial humanitarian topic can grow. It already does exist. There's the coalition. There's also the healthcare endangered community of concern that brings together multiple stakeholders, first and foremost representing the global health workforce. And I hope that in the coming years we'll see increased practical engagement on this topic, especially by ministries of health who have particular legitimacy to lead on this issue. And I also hope that the negotiations on the so-called pandemic treaty, but also everything else that we're witnessing these days in the diplomatic sphere, and which is partly owed to the additional spotlight that the pandemic has put on the well-being of healthcare workers, that all of this leads to more practical and concrete action, especially at the national level, in order to make sure that healthcare workers, the people that they care for, and healthcare transports and facilities will be safer and more secure in the years to come. Thank you very much.
Thank you very much. Len?
Thanks for this opportunity to join the discussion. I'd like to reinforce a couple of points Maciek made, which is, number one, the important role of ministers of health, and allied to that, local data collection. I think we haven't talked enough about that, and it's critically important. And I think this discussion we've had about data versus action, I think is not the right discussion. We need both. We recognize if you use Ukraine, where there's been more reporting than anywhere else, if people are not held accountable for these atrocities, I don't think questions can be raised about what's the point of data. We need to take action, but it doesn't mean that collecting data is not important. Thank you.
Thank you, Len. Fortunately, I don't think that Tubicho is still here with us on the call. So I'd like to end with really reinforcing the call for broader cooperation for the protection of the medical mission in armed conflict. And I want to thank you all, to all our panelists, for this really rich discussion. And again, the government of Spain for the support. I encourage all of you to read the IPI report, which you can find on our website, and to continue engaging on this important issue with all stakeholders. So thank you very much again, and have a great rest of your day.